Hello, everyone. Can you hear me all right? All right, so today's presentation's on mitigating vulnerabilities using information sharing. So if you're not already familiar with information sharing centers, we'll jump into that and kind of explain what that is on a couple housekeeping slides. But before we jump into that, I am Joshua Justice. I'm a CTI manager at Health-ISAC, and I'll pass it over to Tyler for a quick intro on kind of his background.
Yeah, sure. My name is Tyler Curry. I am a cyber threat intelligence analyst at the Threat Operations Center for Health-ISAC. Prior to joining the team, I performed migration configuration tasks at a healthcare delivery organization. And that's what I did prior to joining the team here with Josh.
All right, thanks, Tyler. So just a little bit more on my background. Prior to Health-ISAC, I did work for University of Florida's Genetics Institute. So that's where I learned a little bit more about healthcare, and then more importantly, keeping that information private and confidential. I worked where there were a lot of folks doing research, and sometimes when people have to type in a password to get access to something, you can kind of tell a lot about people. And I started seeing people hitting caps lock and doing really long passwords 10 years ago, before you started seeing that as like a required standard to use 14 and 16-digit passcodes. So I started learning about security there, but then ultimately got picked up by Health-ISAC. I did work for Booz Allen Hamilton briefly in a cyber internship, and that also gave me a lot of insight on how this business works and where I might be able to be useful. But we'll go ahead and move into the next slide. So I won't slow down too much. I do want to make sure everybody's familiar with what an ISAC is. There are 16 of them or more. There's one for each of the critical infrastructure sectors. So water, for instance, has one. Electricity is a big one that we work closely with to find out what's going on with the grid or any issues there that they want to share out. And kind of similar to the previous slides, where CISA doesn't put something out if it's not relevant to a large audience. Kind of what we do that's a little bit different is we'll put something out as long as it's relevant to healthcare. So that might not be relevant to the larger sector, but we'll put that out because it's related to healthcare. But the information centers, the sharing centers, they were stood up off of PPD 63, which occurred back in 1998, I believe. It was a presidential directive for private sector to communicate better with public sector and collaborate and share information as incidents are occurring. The big takeaway from it is that as one entity, one healthcare provider or insurer, or some healthcare organization that you might go to, a hospital is being attacked, they can quickly share how they're being attacked with other hospitals or healthcare providers so they can mitigate or prevent those attacks without having to get every lawyer in the room to have that conversation. So that's largely where the ISACs kind of came in. And again, they exist for multiple different verticals, including financial services. Space ISAC's a fairly new one. So if you're concerned about threats and intergalactic space, they're keeping an eye on that. But I'll go ahead and move on to the next slide, which focuses more on Health-ISAC specifically and kind of what we do.
Yeah, sure. So as the name implies, we focus on healthcare through a number of different initiatives. Those typically include, serving as an information hub or a platform for organizations to come together and share information about threats or vulnerabilities that they are either monitoring or have encountered, so that other healthcare organizations can protect themselves against similar threats, attacks, or activity just in general. We also share guidance and mitigation strategies to help improve cybersecurity practices. And we also foster collaboration amongst, healthcare stakeholders so that we can ensure that we're helping, help ensure resiliency throughout the sector.
Yeah, and just to add on to that a little bit, one of the items that we also focus on are events. So as much as we try to be a trusted organization of peers, where everybody can get together and share that information in the middle of an incident, you're probably not going to do that unless you've actually met the person at another organization or healthcare provider. So a couple times a year, we have summits in America, and we also have summits in Europe and Asia as well, to kind of help allow people to shake hands, get to know each other, trade some business cards, but at least get somebody you're connected to on your LinkedIn profile so that when there's an incident, you see the domain for who it's, who's being impacted or who might have an email address that's compromised. You can reach out to your friend that already works there that you met at one of our events or a workshop or the speaking engagement here. Maybe you met one of the analysts that works on the team. So you reach out to us directly after you've kind of met us under those circumstances. But that's Health-ISAC. All right, so jumping into kind of the focus of today's presentation, specifically on healthcare. So again, the last hour, if you're in here, they spoke about known exploited vulnerabilities, which just kind of impact everything generally. If you're familiar with attackers or if you study threat actors, they generally are not targeted to one specific thing they're passionate about. Those are hacktivists. They usually don't try to get money. What you see more often are just people that are quite talented at exploiting vulnerabilities and attacking anything they can get money out of. And that includes healthcare. There were some threat actors for a while that claimed they didn't touch healthcare. They wouldn't mess with it. They just focus on electricity or other organizations or sectors. But that's significantly changed in the last 4 to 5 years. We've seen a big uptick in attacks on healthcare. And that's kind of the point of today's presentation, is to walk through some of what we keep a close eye on and what we share with the sector to kind of help them be more resilient against these types of attacks. So at a high level, we have those couple housekeeping slides, just kind of let you know what an ISAC is. We're going to jump into these HIPAA protected DICOM files. There's 5 different types of attacks we'll speak to, and then we'll speak to some vulnerabilities that we've reported on just in the last 30 days alone, and then just kind of a looking forward, what we expect in the future.
Yeah. So, as we mentioned in the previous slide, there are some concerns that we have regarding weaknesses for the DICOM protocol. Some of the things that we've typically seen, themes that are common within our sector, or seeing how threat actors are leveraging or maliciously using, that protocol to be able to scan patient data, get access to gain unauthorized access to patient data, images that are private to the patient. If you've had any type of medical imaging, they provide you with that data, usually on a CD or something that you take to the receiving hospital or private practice. You wouldn't want anyone to have the access to that information. Usually most of the times threat actors are taking that data if they want to either, extort a hospital, or they want to, potentially, target a VIP patient, you name it. Those are the different things, the avenues that they can use once they get access to this information. And that's what, we're here to do. We're helping to try to protect that information, or at least make organizations aware of some of the common things that we're seeing in the sector, so that they can, bolster their security posture and make sure that they don't get access to this private information. But as you can see here, the headline, although it is, it's pretty recent. It's something that we've seen since we've joined the team, around 2019, 2020. And it's something that we're trying to begin to chip away at the problem. And that's part of, what we do as an information sharing and analysis center.
Yeah, just to echo Tyler's point there, this is a headline that we pulled from December 2023, but to this point, back in 2019, when we joined the team, this was an issue that was brought to our attention by our CSO. And we initially started attacking it from the vendor perspective. Let's reach out to the vendors and get the defaults corrected. That wasn't met with as much progress as we'd hoped for. So then we moved into kind of conducting an inventory of all of those systems that are out there, determining owners of them, so that we can make notifications. We got a question? See if you can bring a microphone up for you.
I know a lot of the healthcare devices don't get patched regularly. Clinical engineering always has to do a lot of testing on a lot of these things, for like even cardiac monitors, x-ray machines. How do you deal with those issues where they don't get patched regularly as an industry? Because if it ain't broke, don't fix it. How do you guys deal with that as a culture of saying you need to actually do that, even if it does involve temporary downtimes? Or how do the industry handle all that stuff?
Yeah, so I think it comes from pressure from your competition. Obviously, everybody should be keeping everything updated, but I'll pick on Ivanti. If you get a brand that gets a reputation for having a lot of products that are vulnerable or having issues, it'll effectively destroy that brand. So then the organizations, the brands that have been around for 15 years that do invest the time and research into making sure they're secure, those products end up being the ones that stay in the clinics and end up being distributed. Okay, yeah, you're getting a little ahead on us. We do. Yeah, that's a great question though. We do inventory all of the different CVEs that are related to medical. We track all the DICOM and PACS vulnerabilities that are out there. And then once proof of concept code gets out there, once there's some intelligence around people leveraging it for the wrong reasons, that's where we'll reach out to them and say, hey, we've told you about this vulnerability for 3 or 4 years now. Now we've got a researcher who's decided to put a step-by-step guide on how you can take advantage of that protocol in order to gain access, unauthorized access to an organization. And it's especially concerning because these are medical images. These are image servers. A lot of times they'll break in through maybe a VPN or something like that. But then once you're through there, you still have to pivot and get to where you're trying to exfiltrate. If you think about Move It, that vulnerability that occurred last year, they were sitting right on a tool that they could exfiltrate through as soon as they found the vulnerable system. Similarly, these DICOM systems, you can pull the images directly from those without even navigating further into the network where you can trip wires and let the security teams know these are already out there, and threat actors can quite easily just pull some metadata, share a sample of that metadata to say, here's the patient name, here's an elbow x-ray they did a year ago, and here's a knee x-ray they did two years ago. Clearly we have visibility, pay us, and we'll so we try to avoid having those incidents occur by bringing to their attention the products that are vulnerable as soon as we become aware of the fact that there's active exploitation of them. But it really comes down to that incentive that they have to protect their brand reputation, that they have quality products and they stay updated with the most current updates available. Sure. Slide. Yeah, so I think I was mentioning that we had to kind of take an inventory.
Yeah, so we use a number of security partners and scanning tools to find medical imaging servers. One useful or valuable tool in particular is Shodan. For those who may or may not know what Shodan is essentially a scanning tool that allows you to identify or locate devices that are connected across the internet. These usually include anywhere from routers, or firewalls, whatever have it. If it's connected, you can likely find it using Shodan. And one case in particular where we utilize Shodan is for the medical imaging servers. I think it was last year, 2023, where there was, if you can think of Jira Atlassian Confluence servers, where there was a vulnerability out that we were able to identify our member organizations. And sometimes it's even non-member organizations. If it's healthcare, we try to find a contact for that organization and let them know. But specifically in this scenario, we contacted all of the member organizations that were impacted by this vulnerability to let them know that, hey, there's this vulnerability that's out, it's unpatched. It's best that, or we encourage or recommend it, that you disconnect until a patch is made available. And we keep those communications going on with those members. These are things that we routinely check. We'll let them know, hey, we see this. And, to the question mentioned previously, we see these things going on, and then we'll check periodically. If it's still up there and we can see it, we'll still double tap them and let them know. It's a friendly, reminder, like, hey, this is still out there. This vulnerability is still unpatched. It's recommended that you do, disconnect or apply the patch once one does become available. But just to try to put it into perspective, around the time of building out this slide deck, as you can see here on the graphic, there's still over 4,000 of those servers that remain exploited. Of those 4,000, 1,000 of them are in the US. So it kind of puts into perspective some of the things that you can see, or some of the data that you can come across utilizing this tool. And, it can be used, obviously, unfortunately, for malicious purposes, but, obviously our goal here is to let the good guys know, hey, this is what's going on. Bad guys can see this too. And you may want to action this information that we're sharing with you.
Yeah, to Tyler's point there, I would say there should be a happy face on this slide because, again, 3-4 years ago, when we did this initially, we had 10,000 results, and we went ahead and exported them and started trying to go through and figure out who owned every single one of those 10,000 servers. That ended up being too much for us to keep up with. We're only about 5 people on our team. So ultimately, we've just had to continue chipping away at the ones that typically in the US, and then the ones that we can find a healthcare clinic on it. So a lot of times, if you tap into these and just look at the metadata that's being shared on it or leaked out, there might be 25 different clinics or 15 different clinics that are all using some provider for their imaging. And there's not a whole lot we can do on those. Whereas if we find one and it's all owned by the same healthcare entity, we can reach out to that hospital association and say, hey, it looks like your system's exposed there, and kind of bring that to attention. So we've been able to chip away at that, both from the vendor angle and then reaching out directly as soon as we see these Diacom servers, if we can identify who owns them based on the metadata that's in there. One of the things that's kind of a fun story is on occasion, as we're moving through and we find a server, most of them don't have images on it ideally, but threat actors can still get into them. We'll discuss some of those attacks later. But sometimes you'll get into them and you'll see that all the patient names are Fido, and it's another dog name. Different pet names. So obviously we've encountered a veterinarian clinic at that point, and we don't send targeted alerts to vet clinics to let them know that your dog's x-ray might get out. Things haven't gotten that bad yet. So hopefully they won't get that bad. But just to point out one other thing, we had Shodan, just the basic version. A lot of people here probably use the basic version, the free version of Shodan. You cannot search for Tag Medical using the free version, which I like. So you do have to at least have a paid relationship with Shodan to have that search query available that allows you to enumerate all of these servers and then take the next steps if you want to kind of move in and determine whether or not those servers have images on them and how to reach out to somebody who is responsible for those images to get those taken offline. So the next slide here, this just shows the last 4 quarters of 2023. These are the attacks that we've inventoried on healthcare. We do inventory every single breach that occurs in any sector. Initially, we were only inventorying medical, but then our members made it clear to us they want to know about any breach that occurs, because they'll have a third-party relationship with somebody who maybe delivers their lunch or something, whatever it is. They might have credit card information or sensitive information, so they want to know about it. And these attacks were down in the single digits 3 years ago when we first started tracking attacks in the sector and all the critical infrastructure sectors. But now we're seeing that healthcare is the most attacked out of all of the sectors, likely due to the fact that there are care systems that need to be up, and there's a lot of incentive to go ahead and get the system back up and running, which often means cooperating with threat actors or finding a way to work around those threat actors to get your business up and running again and be able to deliver care to patients that need surgery, or, as we've seen recently, prescriptions that are being interfered with and surgeries that are being rescheduled due to large systems that process the data behind the scenes being impacted. But we put out a quarterly report on these observations that we've seen based on the breaches. And this is just a snapshot from one of those quarterly reports. It's a consistent increase. It's not, there's never a quarter that drops all of a sudden. Even with Move It jumping it up quite a bit there in Q2, Q3, we still saw just as many events that were occurring as threat actors continue to target healthcare organizations. Most of these are small hospitals, small outfits, but obviously there are some larger entities that do get targeted as well. But on that note, we'll move into some of the attacks on these systems.
Yeah, so the attack one here, this usually entails the compromise of a device. In this situation, is likely the PC that's actually used to create the CD for the patient. Most of the times this occurs where the PC gets compromised, usually by sometimes clicking on a malicious link or opening a malicious PDF or file in a phishing email. Once that compromise actually occurs, that PC that's used to create the CD, the malware that gets on it usually causes other executable files on the device to also be infected as well. So when the CD is created, they create an executable DICOM viewer, which is a default executable that when you plug it into a computer or a workstation, it runs the image. You're able to see what is on that CD. Unfortunately, in this situation, that DICOM viewer executable is now infected. It's actually on that CD, and that's what's actually used to permeate or infect potentially a PAC server or workstation once you take it to the private practice or the hospital that the patient goes to. So as far as some prevention or ways that you can try to avoid this type of incident is, implementing antivirus on the end of the media creator and the actual device that's used to import the images. actually having a fixed DICOM viewer application on the device that actually imports the images. That way, you don't have to worry about using any old flavor of a DICOM viewer that comes on any CD that was created from a previous facility that the patient may have went to that was used to create the CD. So that way you can avoid having this overflow of unnecessary DICOM viewers, running within your environment. You're actually using a well-known DICOM viewer or a process that your organization or that organization in general uses to actually view the information. Another way is to, this is just to help prevent the spread of the actual compromise, implementing proper security tools throughout your network, firewalls, routers, network segmentation, so that in the unfortunate event that if something does happen, you can try to mitigate the likelihood of lateral movement throughout your network based on this simple compromise that came from a CD that was infected from a prior workstation or DICOM PAC server, or that was used to create the CD in general.
So moving on to attack number 2, I think this one's also pretty challenging. Attack number 1's a challenging one also. Attack number 2 deals with local, meaning you would actually have to go to the hospital and sit in their waiting room with your laptop, or maybe out in the parking lot with a big antenna. But the idea behind this one is that they sit on the network, and by default, DICOM does not encrypt. It's all moving back and forth across the network in plain text. So if they're able to hook into the network locally, and that DICOM communication's not encrypted, then they can pick up all that same information I was speaking to earlier, as far as the metadata, name of the doctor, the name of the patient, the name of the item that's being x-rayed, or the imaging that's being done on it. So you would think it's pretty unlikely that this occurs because you do have to be in person. But it is something we see more from a digital or more from a virtual attack. And I'll move into that in number 6 when we get to that. But these are ones where you actually sit on the network and intercept the traffic to gain those insights we spoke about earlier. How to prevent those types of things. You can use TLS or just any of the basic standards that we all use to kind of encrypt communication. You should just be able to kick those on and not use unsecured communications for those systems. And that'll prevent somebody on the network that's just joining maybe the guest network and the wireless network that's for patients in the waiting room. That'll prevent them from being able to get access to those systems. So again, I know anytime you read about an attack and it requires local, most of us kind of move on to the next attack because it's not typically what we have to worry about. But obviously, as threat actors get more desperate, this will become more of a concern, just to make sure you tie things down physically and maybe use some web portals, captive portals, to make sure you know who you're bringing onto your network if they're coming on as a guest.
All right, and attack 3 usually, these ones get it. This attack and the ones thereafter usually increase in complexity. This attack specifically, more or less, you'll see this start to be leveraged by really sophisticated threat actors, nation state threat actors, because they have a deeper understanding and knowledge of what to do after they get into the network to be able to further their operations. But in this case specifically, this is embedding malware into the DICOM image, where essentially they are the image itself is already compromised, but it doesn't actually execute until it's actually open. So what happens is the image is embedded, the image is now into the system or the PACS workstation or the diagnostic workstation. It stays dormant until later on, where someone in the radiology department goes and actually opens the image. It now executes and it goes and permeates throughout the system. Obviously at that point, it's behind the firewalls, behind any security tools that you may have, so you can't, detect the initial access that occurred until you start to later on do some of the prevention mitigation measures that I'm going to obviously speak to in the next slide. So in order to prevent this, you want to apply rigorous application testing on systems that actually open and read some of these documents. Some of the recommended mitigations are to obviously update your systems once you know, or if you know of any vulnerabilities that are a part of any processes, any software libraries. that may have that you can update. Just stay abreast on some of those things that that either what you currently have is outdated and needs to be updated. One of the main things is a bitstream validator, which basically allows you to identify or detect malformed documents such as embedded DICOM images so that you can prevent its processing and opening of that document and therefore prevent the malware from executing within the actual system and spreading throughout your network.
All right, so attack number 4, again, this is another one that's a little bit out there. This is where a threat actor compromises the network for the sole purpose of manipulating the existing images that are in there. So let's say the image has cancer, they remove the cancer. If the image does not have cancer, they add cancer. So I was kind of racking my brain on what scenario this would actually make sense for a threat actor to leverage it. And it really doesn't it doesn't have that many scenarios where you could turn this into money. But then going a little bit further to competitive intelligence, if you have a couple hospitals that are competing and not sharing information and not collaborating, there is incentive theoretically to make one doctor or one hospital system less effective at determining what's going on with somebody. And all of a sudden, this clinic over here gets a huge reputation for detecting cancer all the time. And all these other guys don't have that reputation because for some reason they're missing it and maybe it's malware. Question?
Going back to the previous slide. So some of the assets in question, they're not actually like servers, like they're appliances. Some of them are running archaic versions of Linux or Windows. They don't have antivirus because the vendor hasn't included that. Have you given any guidance to healthcare facilities on what they should be doing to actually protect those and minimize that potential exploit being compromised, that system from being compromised because they weren't designed with security in mind. So they're just, again, more functional, but there's nothing really stopping a lot of this stuff from happening. Have you given the facilities any guidance on what they should be doing, or is that beyond your scope?
No, definitely not beyond the scope. We'll move into a couple alerts here that we've shared, and what we'll do is we'll share the alert, but we'll provide some guidance on how to mitigate that attack. I know Tyler mentioned that network segmentation, so there's always approaches there that can make it more challenging. It is not impossible to secure these DICOM systems, but they are by default weak. They're just by default, and the defaults when you pull them out of the package and plug them in, they're vulnerable. They're built for availability. They're not built for confidentiality. So it comes down to that guidance that we provide. Hey, segment this one, but more importantly, pointing at the systems that are ones that maybe they should steer away from because they're continuously having vulnerabilities. You probably follow many vulnerability feeds, but how frequently you get a heads up about DICOM related stuff is probably infrequent because it's not that widely used and it's not where at least most people in theory believe that that's not how they're getting in for attacks. I think it's quite possible that it's an effective vector for getting in than deploying something without anybody knowing that your first vector was a DICOM system or something of that nature. But we'll show you a couple of the bulletins that we share. On the next one, we covered this, right? I'll jump. All right. All right, so it's you do 5. Sorry.
So attack 5 here. So with the DICOM systems, they leverage a communications protocol or system. Its abbreviation is HL7, stands for a health level 7. A health level message 7 is essentially used to keep information across radiology, hospitals, and PAC systems, keep it consistent based on for the patient. They're able to update the information, enter information for the patient. Just basically just a means of communication of the data that's being utilized. So in this situation, this is obviously post-compromise, or once the threat actor is already within your network, they're now going to try to manipulate this communication system because it's not built with security in mind. It's very easy to compromise. One of the things that they will do is that they're able to send update messages or create messages to either change legitimate information for the patient record. This is going to essentially make it pretty much impossible, not impossible, but very hard to fix. And it's going to cause significant downtime because now you're manipulating patient records. You don't know, what images belongs to whom or what have you. And essentially what they can do is insert their own malicious messages within the communication system to kind of throw off the whole equilibrium of the whole system, and everything at that point is essentially, this is a disruption attack. It's basically going to make it that much harder for you to maintain patient records, update patient records, and that can lead into a whole host of issues for the healthcare entity in that scenario. So prevention measures, and again, you'll kind of hear some of the common things throughout the prevention measures. Obviously, TLS encryption, or just encrypting your data across the network. Making sure that you're utilizing, this is a pretty creative one, is application logic that will allow you to pick up on anomalous activity. If an update record, which doesn't usually happen all the time, is over and over you see those signals going throughout the network, it's kind of a tipper to let you know, like, hey, there might be something going on here. Or just if you're receiving a certain type of process that related to the health level message system, is that, if it's basically anomalous behavior, it allows a trigger for you to go investigate and see what's going on. And then also just making sure that, I think I already mentioned, but encrypting your communication, making sure this is that much harder for threat actors, if they do get behind your systems, is to make it hard for them to decrypt or understand what that information is. And obviously, the network segmentation, implementing security controls so that you are able to stop the flow of a malicious operation that's currently trying to take place within your network.
All right, thanks, Tyler. So we don't have a slide for attack number 6. I had debated not covering it, but we have a smaller audience here, so I feel like it's okay to share it. There is a fairly new tactic that we've seen. It's consistent with some of these attacks, but it involves people that are overseas and becoming virtual patients. So this one, everybody will get this. So if you go to a hospital and you want to have somebody do the diagnostic and help you heal, part of that is that they do an X-ray or they do some imaging to find out what they see inside of you. But if you approach that healthcare system and say, hey, I already went to so-and-so over here, I've got my disk, like you mentioned earlier, I got my CD-ROM, or maybe I just have my file that has it on it. Can I just email you my file that has all my X-rays on it? That happens every day. And then there's that risk that that's a bad guy and it's a malicious DICOM file. And when he sends over that file to say, hey, I'm a new patient, let me know how you can heal me, as soon as they detonate that file, that system becomes vulnerable. So how do we fix it? To your point, you kind of have to automate the entire process down to that network segmented area. You have to use like security orchestration tools to rip apart those files as they're coming in and detonate them and confirm that they're not malicious files. So that's an attack that we've seen here more recently, where they're coming in as virtual patients, and what they'll do is steal somebody else's identity and appear to be somebody local. But then when it comes to handing over a picture of a knee, you can't tell from looking at a picture of a knee that it's not somebody else's knee. So people will go ahead and bring that file in to the folder that's for that whole patient, and then that will effectively compromise that system. And then our belief is that they utilize that initial access to then drop an AnyDesk or some remote access tool that everybody's used to picking up on. And when your third party comes out to try to figure out how you got popped, it looks like those AnyDesk got deployed, but how they get in there to begin with to drop that AnyDesk. So we have pretty high confidence that they're leveraging these systems that by nature are built to provide care. And as long as you have a room full of people who care and somebody comes in and says they're sick, they're going to double click to try to heal them. And that's becoming an issue, and it'll continue to be an issue into the future as we become more virtual and people will go into offices less for healthcare. We're going to have to get a little bit better about vetting every single file or picture that's sent over by a patient to confirm that those are not booby-trapped. So just being mindful of time, we are going to move through some of the vulnerabilities that we've reported on here recently. Just on a timeline level, I know we're pushing a little bit on time. These are 4 that occurred in the last, just the last 30 days. So you can see there's 228. There is the DICOM viewer vulnerability. Then we had a micro viewer vulnerability. DICOM framework proof of concept was put out. And then that Sante, the same brand that had the viewer, had an FFT server that's also vulnerable. So we'll quickly move through those. Those are some examples of the ones that we brought to folks' attention just in the last 30 days alone.
Yeah, so just recently, I believe this was February 28th of this year, we actually distributed a vulnerability bulletin to our community or healthcare members regarding, the matter. It's letting them know, hey, this is what's out here. These are different things that threat actors are looking to exploit. And as Josh mentioned earlier, it's not really on the radar for most, but it's just kind of letting them know, like, hey, these things are real. This is real. There are threat actors out here that are trying to leverage this. And as I mentioned earlier, they can use scanning tools like Shodan to even try to identify and pick at whichever ones that they want to try to exploit, because it does that for you. It shows you which ones are out there, shows you what they're vulnerable to, and which one to, spread the word and, echo the sentiment that this is vulnerable, this is actually being attacked. And, this is something that they can use as a attack vector to get into your systems and, wreak havoc.
Yeah, so one of the things we've been doing more recently, we inventory all of our members, obviously, and keep track of their domains for trying to protect their infrastructure. Here recently, we've also started inventorying every viewer they use for these types of systems. The reason being, when these bulletins come out and Sante DICOM viewer is vulnerable, we'll have a short list of the ones that are actually using it or that we know these organizations or these hospitals are using this viewer, so that we send targeted alerts to those instead of just a massive bulletin that hits everybody it doesn't apply to. We'll reach out to those 5 entities that we know are using that specific viewer to give them a heads up that they usually it's just update to the newest version. But that's it for the Sante DICOM. All right, so the next one I want to bring to attention is the micro DICOM viewer. So this is very similar to the one that Tyler spoke to. This came out about 3 days later after the one that came out for Sante DICOM. This one hit home for me. I personally use it. It's one of the tools that I use for determining whether or not systems are empty, if they have no images on them or if there are images. So as soon as I saw it, obviously it hit home for me to go uninstall it and go get the most current version of it, updated version that had just come out. But a lot of times CISA doesn't put things out unless it hits a larger audience, but they're really strong in these medical advisories, which is something we always focus on. And then we have a dedicated team internally that handles all the medical advisories, unless they're DICOM. As long as they're DICOM, that one stays with Tyler and I to continue our research, because as we mentioned earlier in the presentation, we've kind of been hunting this for about 4 years now, and progress is being made. We certainly won't take credit for it, but it is moving in the right direction. And so we stay focused on that on our team.
Right. So with this slide here, this actually speaks to what I just mentioned previously. We distributed the vulnerability bulletin on the 28th of February. By the 29th, there was already communications out there that, there's researchers looking into this and trying to find ways to exploit it and create their own proof of concept. And this kind of, adds to the severity of the matter, because once these things become publicly available, it's not just the researchers that are going to look into this. The bad guys are actually going to have access to it as well. And they may even utilize it to, utilize it within their own malicious operations, or take pieces of it to create their own proof of concept or exploit code to, exploit the actual framework in mind here. So this is one of the things that kind of bring truth to light, why we do what we do and send out these informations, because now it's not just a vulnerability bulletin. We distributed a threat bulletin on it now, because this is something that's soon or should be occurring, because, you have people out there that are discussing it and trying to find ways to exploit it.
Yeah, so initially we were sending out these alerts about vulnerability bulletins and threat bulletins related to DICOM systems, but we didn't have the evidence we needed for proof that it was an issue and that threat actors are compromising it. But as of about 2 years ago, CLOP, if you were following their chat logs when they got leaked, if you read through line by line, they actually brag about taking advantage of DICOM systems and medical imaging systems to break into organizations. It was when I read that line that I started suspecting that they might be doing that more frequently with healthcare organizations, and then deploying those remote management tools to kind of make it appear as though that's where the initial compromise occurred, was the remote management tool. So did we download this proof of concept and test it to make sure it worked before we shared it out? No, absolutely not. And to CISA's point, how they don't share out proof of concept, that completely makes sense for our audience, though, that's tracking this. We want to know about it. We picked this up off of one of our scrapers. I'm sorry, we picked this up off of one of our scrapers and then validated it, converted it to English, and then read through it to make sure it was correct. It is correct. It is actually how it works. So then we went ahead and distributed it to our membership, and that gives a lot of teams the support they need to bring the leadership to say, hey, we need this other tool that can look at every single DICOM file that somebody supplies to us to make sure that it's not infected, or we already have this tool and I just want to have every file that comes in run through this tool to make sure that it's secure.
All right, so with this slide here, this one it's unique in its own right, because this is something that came out within a week of the actual vulnerability bulletin that we put out about the DICOM viewer. This now was pertaining to the actual server. So it kind of just brings to light the different things, you know, that threat actors gives them another loophole or another attack vector to try to take advantage of. And we just wanted to highlight this to show how quickly some of these things can develop and different ways that they can, you know, mutate into different avenues that threat actors can try to leverage. So that's just what we want to highlight here with this slide.
I dug a little bit into this FFT imaging. I can't imagine anybody's familiar with it. It's actually a tool for taking those DICOM files and removing some of the noise to make them a little bit easier to read, which obviously if somebody compromises that FFT server, they can do exactly what was described in, I think, attack number 4, where they can manipulate the data that's actually there to kind of make it tougher for healthcare organizations to deliver care. All right, so that brings us to kind of looking forward. This is towards the end of our presentation. We do have a few minutes for Q&A also, but just looking forward, our plan is to continue to do similar to what you see here. We'll continue researching these. We'll continue to share with the sector once we have things that are relevant to them. But also we want to kind of lean on people that are out there that go to hospitals and healthcare practitioners. If you see anything or if you spot something in the news, don't be afraid to send it over to Health-ISAC for us to add it to our inventory, review it, and maybe you do have a lot of contacts for letting every hospital know that there's vulnerability, but a lot of times that's where we really shine. As somebody, a researcher, will do a ton of work. The DICOM and the Sante, that was Michael Henkel that did all that research. Michael can't get a hold of all the people we can. So instead of him having to send out, 800 emails, he can reach out to us and we can get that out to a wider audience so that they can kind of secure their organization and make it less likely that your information gets breached and you get a year of free credit monitoring. Go ahead, Tyler.
Yeah, so the status of PACS DICOM, this infrastructure or this technology isn't going anywhere. It's going to continue to remain to be the backbone of the medical imaging data. So therefore, we believe that this will be something that will remain a high value target for threat actors, whether it's to be for them to be looked at as a cash cow or quick cash out malicious operations, to pull that data, get that data that has very private information on it about patients and hold it over the entity's head that, hey, we're going to put this on the dark web or you pay us. So this isn't going anywhere. This will always be likely always be something that threat actors will target. As far as other technologies, doing some research on the matter is, removing the PAC systems from that on-premise, if you can, that on-premises standpoint, and putting them in the cloud that allows for more redundancy, scalability, and probably some other security tools that you can probably implement to help you identify and monitor malicious activity that's targeting these systems. Also, you hear a lot often zero trust security, that speaks to the health level 7 messaging system. It's very easy to try to manipulate communication systems like that. But when you have these guardrails in place at almost every step of the way, you can try to maybe mitigate the possibility of those types of things occurring within your systems. And then just information sharing outcomes. We like to share this information with, members, non-members, anybody in healthcare to obviously for continuous improvement, sharing knowledge so that you can basically make the healthcare sector more secure. This is our data, your data. Anybody's ever been to a hospital, you want it protected. So, we do what we can to make sure that that information is kept private and secure for all patients. So.
Awesome. All right, so that does conclude our presentation portion, but we will move to questions now. That looks like we have about 5-6 minutes left. So we should have room for maybe 3 or 4 questions.
Thanks, Faye. So we are a vendor that provides software to just about everybody, all the critical national verticals. We do mapping and GIS and stuff like that. Doesn't really matter though. How would we as a vendor best engage across industry vertical ISACs to make sure our advisories go into the right hands so that those folks that are consuming the advisories through your groups know to take action or know that we've provided a patch or know that we've released new CVEs? Like, is there a clearinghouse of aliases or something like that that we can reach out to, or is there a way that we can sign up to be a provider in order to give you the information so that you can disseminate it out to a broader audience?
Yeah, we'd love to work with you. Can I ask what TLP you'd be sharing that at? Would it be white or would we have?
It'd be clear. It's
Okay,
it's,
clear-
pub- it's,
clear,
pu- it's
yeah.
public advisories.
Yeah,
we-
as long as it's
we-
TLP white, TLP clear content, then yeah, we would love to share that out with our members. I
Okay.
don't see any reason why we couldn't do that. We do vet it first to make sure, it makes sense for what we want to share out there. But yeah, if you want to follow up with one of us afterwards, absolutely, we can connect and I think that would help.
It's not just healthcare specific. It's kind of globally for all those verticals.
No, that's what we do every day is read a bunch of stuff and then try to pick out the best that's relevant to our members and pass it on. So, sure. Looks like we do still have a couple more minutes. I got a question up front here. Just bring the mic up.
I got you.
So I'm actually with ISAC, which is the higher ed. It's really easy for us to identify, who falls under higher ed because most of them are .edus. How do you guys go about determining, who you notify, within healthcare? Are you notifying like all providers or just members? How do you break that down?
So we notify our members. Obviously, ideally, we have a daily point of contact. If somebody becomes a member, they're a daily point of contact. But then every time we send a targeted alert for, hey, we know this system at this IP address is vulnerable to this, please update to this. We include a line that says, if you'd prefer to have these delivered to an intelligence point of contact, please reply with that. So about half of our members, we have Intel point of contacts. These are people who are devoted to chasing this type of intelligence. So we don't have to just distract a CISO, but usually in the absence of that Intel POC, it'll go to a CISO. If we don't have a CISO, it'll just go to that daily POC. But that's how we deliver it to them.
And as far, because I know you guys are ripe for the picking as far as PII goes. And so what kind of percentage are you seeing when it comes to ransomware attacks, people paying versus relying on backups where we know these actors are just sitting on these networks, surveilling for months at a time? Are you seeing more people paying or trying to depend on what they've already got in place?
I think it's a tough question. I think a lot of it comes down to the advice that you're being given. So I know I've been, for whatever reason, I've connected before when people are in the middle of an incident and they'll ask me for my opinion. Don't pay them, they're going to keep coming back if you keep paying them. So don't do it. But there are large organizations that take a different approach, and that can be quite unfortunate because a lot of times it's not even effective. They'll go ahead and try to collaborate with threat actors and then it'll burn them. So we typically advise against it, and I'll elaborate a bit on that story of the one that I kind of held hands on 2 months later. And I don't remember the threat actor, but they were one of the prolific ones. A couple months later, after they leaked the name of this healthcare organization and they were asking us for advice, they came back and said, oops, we didn't realize you were healthcare. We'll go ahead and remove you from our leak site. Sorry about that. It took them 2 months to finally circle around and go away, but they never collected a ransom. They took the stuff off the leak site and they weren't an issue at that point. So a lot of it comes down to the culture and getting everybody to agree not to pay a ransom. But at the same time, if it's interfering with the ability to deliver care, I understand the argument for the other side. It's easy to say, don't ever pay ransom. But yeah, we don't have any visibility into what percentage, unfortunately.
Well, on behalf of ISAC, I just want to say thank you for all the work you do. I know we have a lot of overlap, so you help us out tremendously. So thanks for all the work that you guys put into it.
Thank you. And she jogged my memory on your question also. How do we, like a clearinghouse to the other ISACs, even for that matter? I don't know if you're in it or not, Sarah, but we have a collective instance called Atlas. So we have our, where we distribute our bulletins, but as long as it's TLP clear, TLP white, we have permission to share it out to the other ISACs. We'll share it to our platform called Atlas. And then the other ISACs that participate in Atlas can pull in there and grab it from there and send it directly to their instance to distribute it as content. But it does look like we're coming up on time there. We might have time for one more question in the back there.
It may turn into a question, but it's almost like a call out as well. Yeah, thank you for the presentation, of course.
Sure.
As far as like the vulnerabilities go, network segmentation was called out tremendously at the very, more or less at the step one of it all. And again, in my head, the zero trust model was like the big thing that I think it's definitely worthwhile to push if that's not where organizations that are handling this data you know and what I think is in relation to the zero trust model, what I think of is also the integrity of devices, right? You don't want to be in a situation where you don't know whether or not the integrity of the system is sound, right? Is it the same as it was from the manufacturer as it they intended, right? Or if someone has been sitting on the network or sitting on that device or have any ransomware, of course, right? Worms, etc. It's very prevalent in that space. Being I'm not necessarily in the healthcare space, but being a cybersecurity analyst, like I'm basically within that space. I can see where big issues can arise, right? And I think this discussion has been ongoing for decades. But yeah, zero trust, locking down the network, ensuring that those who should have access, they do have access, and those that don't, right? I'm kind of really locking down those controls. So more or less not a question. Honestly, maybe the question would be of, how much adoption have you guys seen? Given that you guys are more or less using Shodan and other resources, I imagine. As far as zero trust model goes across the this healthcare industry, what's your thoughts there?
Yeah, I'd love to say that our targeted alerts are reaching out, or a few of our bulletins is why there's only 4,000 servers online versus 10,000. But I'd sooner believe that's an adoption of zero trust architecture. I sit on a couple different working groups at Health-ISAC, security architecture and security engineering, and they beat the zero trust to death. It is the way to go to prevent people from being able to access those systems. It's just a matter of how do you actually make it work, and how do you get everybody to agree that it makes sense to use a product that might cost a little bit more, but by default has TLS kicked on or something like that. But yeah, great way to close it up. I know we're on time. So thank you, everybody. Thanks for all your questions.
All right. Thanks, Josh and Tyler. Great job.